All right, so today we're going to talk about malpresentation strategies. So our outline is that we're going to look over different ways to affect the pelvis based on where the baby's at. So we're going to look at strategies if baby's right at the inlet, strategies if baby's mid-pelvis, and strategies if we're looking at the outlet. So that, like on the one hand, as much as mom can be active and moving, and I think there's definitely something to be said for balancing that out with rest too, so we're not completely tiring her out or having her do stairs all day and then we're too tired to push, right? So there's a balance to that, but active movement is great. But if we have an issue, the goal really is, could we make more space for baby based on where baby's head is right now? So we'll talk a little bit about kind of changing how we're viewing progress within that context. And then I'm going to talk a little bit about persistent OP presentations as well as manual OP rotations. So if we can't get a baby to turn, but there's ways that you could turn that baby. That would be within your scope. But often not taught, and it needs to be taught. So we'll get into that when we get there. So changing the progress paradigm, basically the idea is any baby that's coming through, if we know where that baby is, it's not about us turning that baby, it's about us making more room in the pelvis so that baby has room to turn themselves. So thinking about station more so than dilation. Like if you have a mom who's not dilating very quickly or has kind of an irregular labor pattern, but baby's way high and up in her pelvis, if we can create more room or encourage that baby to come in and drop, then we've got a head that's well applied to that cervix, then we'll start to see a cervix change. But rather than honing in really specifically on dilation, to hone in instead on station, that can direct what we're recommending for. And then we'll keep in mind that we've got a pelvis that's flexible and mobile, where we can get at least 2 centimeters of extra wiggle room off of these 3 areas here, right? So if she's laying flat on her back, we lose that mobility. But if she's up and moving around, and especially moving in certain positions based on where that baby's at, we can create more wiggle room and more flexibility for the spot that that baby's at. And then also a reminder that flexion really does matter. So if we have a baby that's nice and well flexed, that's 9.5 centimeters for our widest part. But if we're military, that's 12.5. And if we're even a little bit extended, that's 13.5. And then if we end up all the way in face, we're back to being small again. But then, risk for airway bruising and facial bruising and things like that. But not necessarily hard to come out, but could still be a little rough. So the more flexed we are, the better. And then recognizing, too, that OP babies are more likely to not be well flexed. So if we can create more room in the pelvis, then that baby can turn and get better flexed. And then I think it's also worth recognizing that we're not just talking about a baby's head and the pelvis. There's all these other ligaments and muscles and supportive structures that are surrounding that uterus that are also a factor that baby's having to navigate through to get down, right? So if we look at this cross section, we can see all these different ligaments that are supporting everything surrounding our uterus, so that we're keeping that in mind too. And then you can also add in that layer of muscle, multiple muscles and all of that. So another strategy, in addition to creating more mobility for the pelvis, is if we have one of these ligaments that's like tight and taut and kind of yanking, that's throwing everything else off, right? So if we have a way to soften and kind of release really tight ligaments, then that can bring her uterus into better alignment and let that baby navigate down easier. So some of these maneuvers, based on what baby station's at, will be targeting increasing pelvis size, but also some of them will be about kind of softening and releasing ligaments that are really tight. And that the goal really is balance, so that if we're doing something to one side, let's do it to the other side too, so that we can kind of get that uterus in balance again. Okay, so now we're going to go through strategies based on where that baby's at. So we're going to start with the inlet, then mid-pelvis, and then the outlet. Could we pause for a second and somebody just go grab me a pelvis from the lab room? So inlet strategies, we're talking like -2, -3 station, or you just reach in and baby's just way up there. So abdominal lift and tucks for 10 contractions would be an option. I have a slide coming up that will talk about that specifically. A belly band if mom has a really pendulous uterus. So I'm even thinking sometimes you feel the pubic bone, and then it's like there's a ridge up and you feel the top of baby's head. Like baby's not in and going down. Like baby's just like sitting, resting on top of the pubic bone, right? So like baby's head sitting here. So to encourage baby to come in and then down, this is where abdominal lift and tucks come in, which we'll talk about. But then also a belly band, like if you have, I don't know, a G6 or even a G3, where it's like her whole belly is just kind of hanging forward. And it's like you can feel the head, you can feel the body, like we're not in and down. Like actually just last week I had a mom who'd been in labor for 10 hours and it was her third baby, and her last babies came pretty quick and this one was just really high. And she'd been in labor for a while and was getting tired. And to do abdominal lift and tucks when she came in, like she'd been kind of putting off coming in. We did that for 10 contractions, and then baby finally, like you can feel the difference. Like you can feel this, and then we have head, and then after doing that for 10 contractions, I checked again, it's like, nope, thump. And then we've got that head well applied to that cervix, and then labor just takes off. So same thing though with applying a belly band to just kind of force that pendulous uterus to kind of stay up and in. Not super comfortable for labor, but that's another option that would be similar. Belly band seems great. Figure of eights, so kind of leaning over and doing this, and then going the other way. Why don't we all do it now? I feel like that would, we've had a long day of lectures. Let's just all plan to do that. So start one way, and I'll do this kind of stuff next to mom. Like I don't like bossing people around, but I'll just do what I'm wanting them to do, and then they copy me. Yeah, okay, now we'll switch directions. So helping that baby shimmy, or if she's hanging on to dad, she can do the same thing to just get those figure of eights going, right? Perfect. Sitting on a birth ball, same thing. I don't have a birth ball today, and then just kind of doing hip circles that way too. It's just encouraging that baby to really drop in. So if we're kind of stuck at that inlet, that's a great option. And then we'll see Walter's position as well as Friday Walters. As well as a tub, what that looks like in the tub in upcoming slides. As well as shaking the apples or the apple tree. Does anybody know that one? Oh, we're going to get out my rebozo. Okay, so abdominal lift and tuck. Everyone who's comfortable, why don't we find a partner? Actually, you can mostly just do this for yourself. So stand up. I think it's easier against a wall, but it doesn't need to be. So, you know, anterior and posterior tilts, right? So, like you're sticking your butt out versus then you're kind of tucking it in, sticking your butt out, tucking it in. You'd think this seems like a better birth anything, but not for the inlet. If you can tuck it in this way, like you can picture if this is how you're sitting, if this is how you're normally sitting, and then you do this, versus if you do this, that creates a better spot for that baby to then settle in. So to like kind of pick up that pubic bone and bring it up, so the baby's not just kind of hanging here, it's like it scoops it in. So to do abdominal lift and tucks, you're tucking in your butt, and you're bringing your belly up, and you're holding your baby in during a contraction. Okay, so then when that one's over, if we need to rest or walk it out, we can. And our next one's coming. We're doing that again. And we're going to do that every contraction for 10 contractions. And that's our abdominal lift and tuck. And then I've shown you an alternative option you can do if you do have a rebozo in your facility. Or a sheet works just fine. Let me just get more because I'm going to need So that would be an option. Does anybody want to play labeling leather?
Oh.
I'm going to need so many volunteers by the end of this presentation, so just gear up for it mentally. When your chance is going to be. Yep. So this will be nice and broad across your belly, and then this across over this way. Yep. You get a nice good grip there. A nice good grip here. You might need to refigure this a little bit. Easier when you're pregnant. To have the belly go over, and then during the contractions, you can pull on these. Yep, you'll pull on those, and then that'll help to kind of tighten this and bring it up and in. Just bring it on the bottom again, that pelvic tilt, and do that during the contraction. Okay? Thank you much. Next up, we've got Walters. It looks a little scary, but it's been around forever. So you can see she's got a pretty decent arch to her back. And it's kind of doing that same thing in a way with the lift and tuck in terms of where you see her hips. But again, like for a baby that's just not engaging and needs to get into the pelvis, like our problem's right at the inlet, this is a good option. So does anybody want to come show us the Walters? I will spot you. I'll do it. All right, here we go. Somebody knows they need to get up and move before lunch. And then, so it's really for upper thighs. Let's lock the wheels. Pause. Lock away. Okay. So, yeah, perfect. You could probably even be up just a little bit more. Would that be more comfortable? Yeah, I don't know how to do that. Great. So that would be Walters, and we could hang out there for 3 contractions and just lay there. Does that hurt, or is that uncomfortable at all? Fine. So some people feel just fine like this. Some people, the small of their back, it kind of hurts, in which case you could wrap up a towel and just slip it under there, and that would be fine. When I was pregnant, it wasn't so good. Yeah. Okay, and so then as long as you're here, say you're picturing your L&D bed where it breaks down. The alternative, which I'll show you the picture for Froggy Walters, but the alternative is to just bring your heels together, and then this is just resting on that lower level of the bed. Not all the way broken down, but just down a level. So that would be your Froggy Walters. And you can do that if she's got an epidural, right? So some of these are trickier.
Do you find when women are like this, like, do they have a problem with like the hypotension from being at living in cava and being flat like this?
I mean, any mom that's feeling nauseous or lightheaded, or anytime you're doing any of these maneuvers, if the baby like starts freaking out, whether that's heart tones or just like moving around a ton, just stop. Rare, but can happen. So any baby that doesn't like any position, change. Yep, I've never seen an issue with a baby or a mom feeling lightheaded or dizzy in that position. That's always a possibility.
Is it here for future?
Yeah, I will participate for shaking the apples. Okay. So next one up then is our Froggy Walters. So there's your picture. And then I couldn't find a picture of it, but you could also essentially do a Walters in the tub, and it wouldn't be hands and knees like this. She'd then bring her feet up and rest it like on the tub behind her, so you've got that like big arch in the back. That's like kind of what you're looking for. So she's like laying in the tub on her elbows, and this is way up and back. She'll hate it, but 3 contractions, and then you're done. To see if we can just get that baby past that inlet. That would be your option for your inlet. Okay, shaking the apples. Are you game?
Yep.
Okay. So let's just come on up here. And I think about this one as being really helpful for thinking about loosening up muscles. Like contractions just naturally make people tight and make people stiff in their hips. It's like dancing can help just loosen everything up again so it's not holding that baby. And this is another way to just loosen her up. You can see the variation of like pulling on her thighs with the second rebozo. You could do that too, but shaking the apples or the apple tree. If moms love it, you can go longer. Some people love this, and this is something where you don't have a time limit. You can do this all later if you want to. But basically, you just do this, and you start slow. Are you doing okay?
Yep.
And then you're just kind of doing a jiggle.
Oh.
So shaking the apple tree. Later today, we're having stations where Rebozo's one of them, and have one maneuver that's not this one that I for sure want you to practice, but you may as well practice that while you're at the Rebozo station. Okay? So everyone will have an opportunity to have their apples shaken if they would like them shaken. Okay, so that's our inlet. Then moving to our mid-pelvis, we're talking like -1, 0, +1. Side lunges, so let's all stand up. As much as we love side lunges. So you could do that. You can see the picture there. You could have her up on a chair if you want to have that foot up on a chair. And if we're doing something to one side, let's move it to the other side too, in terms of just, again, this is like any mom. If she's like, I don't know what to do, what should I do? If you know she's mid-pelvis, why don't we do side lunges? But if a mom's like in her groove and she's moving and staying active and doing her thing, and labor's progressing fine, we certainly don't need to get bossy. But again, if we've been stuck for a while, okay, I think I have a way that might help us get unstuck. So being able to offer options like that. So you can lounge back and forth just on the ground for 1, 2, 3 contractions. And then again the other way, you can get her foot up. Yep. So getting into a nice deep lunge during contractions. Take her to her. What?
Not a rolling chair. Chair.
Yeah, not a rolling
Not
chair.
a rolling chair.
Yes, ideally not a rolling chair. Sacrotuberous ligament release. I've got a separate slide on that to show that. Sideline release, they've also got a slide on. A peanut ball in general is going to be best for mid-pelvis. If she hasn't really engaged and she's at the inlet, a peanut ball, honestly, what that's going to do, it's basically doing this to your hips. So that's actually kind of closing off your inlet a little bit. So ideally, we're not doing a peanut ball till we're at least mid-pelvis. So that's a good tool for mid-pelvis. And then we could, again, shake the apples would be another option for this point in the game. Is that a question?
Oh, no.
Nope. Okay. All right. Sideline release. This will be one of your stations this afternoon. What I want you to see here is that for this woman, it's kind of like a straight rectangle here. She doesn't have any twist. If you see that, like her hips are stacked on each other. So this is straight, and then her spine is straight. So we're not like half rolling off the table, right? But basically, when this leg drops over and hangs loosely, you can do that for 1 to 3 contractions, and then you do the other leg for 1 to 3 contractions. That helps open the sacroiliac joint, provides stretching to pelvic muscles that then helps them to soften and make more room for baby. So I think any labor where you've been stuck for a while, this is really good to just do both sides for 3 contractions on each side if you can, so to keep it balanced. That's why you're not just doing one. And then to go from there. Who would like to do sideline release? Brooke, great. Okay, so you're going to lay on the bed here. Why don't we have you face up? Perfect. And then she's going to be about 4 finger breaths away from the edge, so you can just keep coming. And then do me a favor, don't fall. Just stay there for a minute so that we're not falling. And then either a doula or another chair. You can use this here if you need to, just for support. Great, so we're about 4 finger breaths away from the edge, and I'm seeing maybe even just a little closer. Yeah, perfect. And then hips towards me just a little more. Wait, up here for just that. Okay, so I'm seeing that your hips are stacked, shoulders are straight, so we're nice and straight here. And then what I'll do is I'll have you raise your leg until it hits my hand. So now this is straight, and then I'll help guide it over. And then you can just let it slowly release. Great, and then this is just going to fall loosely. And I'm going to have my hand here, in here, and you'll find the right spot. Like this is too far. This is really too much in terms of her hips hanging forward. So you're like helping maintain that spot where her hips are stacked nice and straight. You just let your hands sit there. And it takes anywhere from, I've seen as short as like 20 seconds to a few minutes, maybe 3 minutes. And at some point, this is going to give, and her leg's just going to drop a little bit more. So you're staying here until this is like nice and loose and drops. And you can stay here for 3 contractions, but ideally somewhere in that zone. And this is a nice one too for moms that are having hip issues in pregnancy. Like you could show them how to do this, and they can do this once a day at home too. Okay, feel okay? We're going to stop there, and when you're at your station later, we'll wait for it to fully release. Might take another couple minutes. Okay. Questions on sideline release? Our doula that's coming later today knows it really well too, so there'll be a couple of us around that station if we've got more questions. Okay, so sacrotuberous ligament. You can see it's this one here, this white band here. So it's stretching from basically her spine and the back of her ilium over to her ischial tuberosity. So it's that whole band there. And basically, I mean, you can see how like baby's having to navigate and scoot past that in order to be born. And if somebody's is like super tight in one big old knot, like if you've been stuck at the mid-pelvis for a while, I can sometimes feel it on the inside, like where it's just like this super tight band. Then sometimes if you can just, it's right where her fingers are there, you're reaching on the inside and up, and it shouldn't be painful. So it's mild pressure, but it's like definite pressure there, and to just hold that there for 2 to 3 minutes until you feel it kind of like soften. You kind of give away with butter. Like I had one mom before I knew some of this stuff. I mean, honestly, it was her whole pelvic bowl too, but just so tight. Like I went to do a vaginal exam, and it was like the whole bottom just wanted to suck my arm up, like just so tight. And I think some of these kinds of tools to just like shaking the apples. And I don't know. I want to say she was some kind of aerobics instructor, where sometimes they just have too much muscle going on down there. But same with these ligaments, if you can kind of get them softened. Then they're not fighting baby on the way down. So there's 2 ways to do this. You could do it with her like laying down on the outside, and you could, like, because it's coming just right here. You can see on her bottom, she could still be wearing pants. But you could see on her bottom, there you feel that tight band, and it's just like you're just reaching in and you're holding it there. Some people like to kind of pulse. I feel like I lose it. Like it slips out off of my hand. So if I find it, I just stay there and provide tension there. And usually a couple minutes or so, and you can feel it start to give. You know how sometimes if you have a massage, they push too hard, you're like, I'm going to fight it and stay tense and stay here, and I'm not going to let go. If you can be like not quite that hard, it might like hurt, but you're willing to like let it do its work. So it's not so hard that she's going to fight it and just make everything tight, but it's enough that that you're encouraging it to soften. Like this is the part that needs to soften.
So just to clarify, Katrina.
Yeah.
So that's like you go and be like towards the symphysis pubis, like towards the like pubis bone upwards, or
this is her spine. Like this is her tailbone. So like she, like if, like this would be somebody on their hands and knees right now, right? So it's not anywhere near her pubic bone.
Okay, so it's down towards the sacrum.
But you're angling up towards the sacrum. Like it's like from the back and then up. And then, so you can do it that way, or, and this is probably more often what I do, is I notice it when I'm doing a vaginal exam, like here's the head, boniness, we seem roomy, but I've got like this tight band here, because you can feel it on the inside too. So this picture, you can see it's this one here. That's that ligament. So if I'm doing a vaginal exam, and it might just be one side is just like tight and hard and firm and kind of popped up, like it's in the way of baby coming down, then just right there where I feel it on my vaginal exam, I'll just give it some pressure and we'll just stay there a few minutes, a minute or two. Okay? When I was researching for this, I saw you could do it from the outside. I've only ever actually done it from the inside. And that's true anytime. Like if you're just doing a vaginal exam and you notice there's a really tight ligament, just give it some pressure and give it a little time and see if it'll just melt away for you. Okay, that's mid-pelvis. Now we're on to the outlet. I don't have nearly as much to talk about here. But basically, hands and knees are sideline position. If we're just talking about what makes her pelvis roomier for this stage, outlet's going to be roomier in those kinds of positions. And I think it's kind of interesting when women go to give birth, we're always telling them, like, knees wide apart. But for a minute, just sit on your sits bone and kind of feel it. And then make your knees go apart. Where does it go? It actually angles in. So you'll see, like, some women, you're asking them to push for a long time. You're like, no, wider, wider, and you keep widening. And then maybe everybody kind of ignores her for a push or two, and she's, like, back to doing this, but doing her thing. And then she's actually, like, making some good progress. It's okay for women to push with their knees together. So know that just physiologically what makes more room, that actually makes some good room. So, like, even just when you're thinking about, like, the birth stool, if somebody's on a birth stool and they're like this, like, that's just fine. You don't need to, like, be butterflying, you know, because that's actually going to bring that inlet just a little squishy. And you should do the ligament release again if you're feeling like that's in your way. Yeah?
Can you show them the pelvis?
So these are sits bones. I feel like this one's throwing me off. It'd be like out, like you're bending your legs out, and then these squish in. Does that make sense? I actually feel like the easiest way is to just find it while you're sitting, and then let your knees come out and see how they kind of curve in when you do it. Does that make sense a little? Mm-hmm. Okay. You could do the ligament release again. And I just do that as I find it, if I find that one side is really sticking out at me. And again, I feel like if we've got labor progressing really normally and she's tapped into her instincts and loves her groove, we don't need to be doing anything. Labor's great. At the same time, if we're having things stall us, or if she's, like, looking to you for ideas, knowing where that baby is, you can make suggestions that help just create a little more room for baby to wiggle on down based on where she's at. Okay, and then the anterior pelvic tilt would be better at our outlet. So that posterior pelvic tilt is better for getting engaged and getting in our inlet, but that anterior pelvic tilt, where your hips kind of pop out, creates a little bit more room when we're talking about our outlet. Great. And then just a note on the rebozo in general. So it's a Mexican shawl that's been used to provide relaxation for both uterine ligaments, as well as helping promote optimal fetal positioning. And it's been around a really long time. And I think rather than just starting to use it and not think much about it, I think it's worth acknowledging that that's like a good piece of birth wisdom that's been passed down from our Mexican sister midwives, and we should continue to recognize them. And I think anytime we use it, it's worth saying, this is where it comes from, this is where this knowledge and wisdom comes from. And really in the last 15 years, there were 3 main Mexican midwives that went out of their way to, like, travel internationally and talk about its use and how it can be used in labor. So it's picking up really all over the world, and just want to make sure we're tipping our hat to where it came from. So you can use it in pregnancy for relaxation. I think it provides, like this position here, it really provides that, like, weightlessness feeling, like when women get in the tub and they just aren't having to carry their pregnant bodies anymore. I think that feels really nice. So even just relaxation in pregnancy and keeping things soft and loose and nimble. Early labor, it's generally going to feel better between contractions, so it's not typically something you're doing during, but as a way to kind of reset and relax in between. So for abdominal sifting, does anybody want to volunteer for this? And I'll show you what it looks like, and then this is the main one I want you to for sure practice when you're in your stations this afternoon. And you can see contraindications. If somebody is just always having round ligament issues, then I wouldn't want to risk maybe setting them off. And then otherwise, vaginal bleeding, we don't know where our placenta is, or if we know our placenta is near our cervix, then I would avoid it too.
How long do you do it for?
You don't have a time limit.
Okay.
I would say this is to the extent that they're loving it, you can just keep going. And I'm a huge fan of teaching dad stuff because I get so tired after birth. Yes. So, but it's good exercise. So if you know you have an exercise, hands and knees. And then depending on what kind of technique you're doing, sometimes you're folding it in half. This is one where you want it nice and open and you're covering our whole belly. So now kind of set it up at the top and bottom of your belly there. Perfect. Okay. And worth for you, just in case you're doing it for a long time, really thinking about body mechanics. So I'm just standing kind of on either side of her hips here, and then I've got my hands kind of straight like this, and I'm letting it just kind of run up and over the top, like this. So I've got this, and then I'm going to start slow. So, okay, so once I'm almost in place, I want to bring it up where I've got like a right angle on my elbows. This is more for me than anybody. So when I'm almost there, then I'll give her some lift. So I'm like holding her belly that's been heavy all with pregnancy, and then we're going to just start to do a little bit of this. And then feeling good? Mm-hmm. Doing okay, Matea?
Yep.
Yep. And then we'll just go a little faster. And again, it's kind of like that jiggle movement. You're just going in circles. And if you find that your wrists are really cranked one way or the other, like pause, correct yourself. So you can do it longer. So this would be what you're doing. And then when you're done, don't just stop and drop it because it gets kind of heavier than you're expecting it to be if you're the mom. Okay, so now we're slowing down and then we'll let go. How'd that feel? Great.
We don't have those at work, but we can use like top sheets or the draw sheets is what we use.
Yeah, perfect. I know rebosos are one thing that's like hard to figure out how you're going to clean in between patients. So I don't know how they do, but some people find a system for how they're going to clean it and they make it work. And for hospital systems that haven't figured out a way, use a sheet. Okay. Last one. Have you guys heard of inversions? I don't know many moms who like these. The point of doing an inversion is really not to be upside down. It's after you're upside down to come back upright again. And the act of coming back upright again, the point is like when your uterus is down, like say you have a ligament that's like kind of making your uterus be just a little kitty wampus. You go upside down, it kind of lets it be loose and straightens out. Then when you get back up, it all thumps back where it should be. So the idea is kind of all that supportive ligaments and musculature. Everybody's probably sitting just a little kitty wampus in one direction. But if we can go down, come back up, if we can drop back straight and realign. So, I mean, this is something, honestly, moms could be doing once a day for their whole third trimester. It doesn't matter if they're breech or not, but if they are breech, or if they're lying transverse, I'd have moms doing this like 7 times a day for getting it back again. What do my little notes there say? Oh, you can do it beginning 20 to 24 weeks. But just, I would almost think of this as like a maintenance move for everybody's uterus and just alignment in general. So I think in the rooms, what we'll do is, this is one of our stations this afternoon, you'll kneel on the bed, and then we'll have a chair in front of you, and then you'll lower yourself onto the chair. And I think that's probably the easiest way to do it in the hospital. Like at the birth center, we have couches that are somewhat low setting to the ground, so we'll have them kneel on the couch, and then lower themselves onto the floor, like one foot below on the ground. But basically, let me see, how do I want to do this?
Lower the foot of the bed.
Yeah,
so then they're
that's
kind
true.
of backward, like they're.
Yeah, talk to me about all your
bed,
fancy
and then
bed
the
knowledge.
feet part's totally lower.
Okay, so like it can go low enough.
Yeah,
Go from the
can
bed to the
separate from
ground.
the bed and just go straight down low.
Yeah, nice. Does anybody want to do it here? And if they don't, then I'll do it, and someone can make this chair not roll away on me.
I can do it.
Okay. So maybe you go here to the chair, and I'll make sure the chair stays steady. Okay. So you're going to get your knees up to the edge of the bed, and then you're going to start those stand like this, and then pop up. This is the position you need to end in. So sit up straight. Yep. This is the position that matters. This is the position we're going to end in. So we start here to just mentally remember this is how we need to end. So you can start here. Let's see. Don't have any breaths here. Okay. You don't have to memorize breaths till we do that. Okay. So now you go ahead and lower yourself. Okay. Yep. Hand, elbow, elbow. And I think ideally for her she'd be even lower so that this is like, so this is like dropping straight down. So you can see how it's really steep. That's what we're looking for. And we're going to take 3 good breaths here. It's easy to remember 3, 2, 1. Ideally, 30 to 45 seconds probably would be even better. And then once we've done that, we go ahead and get up. And we go straight up to that up position where we started. 2 good breaths here. Now we sit on our heels and we do 1 good breath there. Done. And we don't need to do that during the contraction. Okay, thank you. This isn't something I picture needing to do all labor long. At most labors I don't do this, but if we're having a labor that's been tricky, whether that's being OP, whether it's just like progressing really slowly, I think it's worth doing one. And as soon as I'd consider doing it again would be if we're still having issues, maybe 4 hours later. But this is something where maybe we do it once in a labor. But it's really good at just reshifting and aligning everything right. And breach, absolutely, this is probably the #1 thing you should be telling your moms to go home and do if you're diagnosing it. Like maybe you diagnose it at 36 weeks, but she's not going to have a birth until 37. Between 36 and 37, we're doing a bunch of this. We're doing moxibustion, whole shebang. We actually have randomized controlled trials on moxie. So keep that in mind. Okay. Questions on versions? Yeah.
Not on versions, but on sideline release.
Yeah.
Is it your hip is for from the side of the bed or your belly? I've only done it where like your belly is like really hanging off the side of the bed.
Let's go back and look at our picture because now I'm confusing myself. I feel like it's intuitive for me, but hard to do without having like a pregnant belly up here. Where is it? Here. Ah, Mom, what does that mean? I feel like I'm trying to make it her hips, but like her belly's not way hanging over, so maybe somewhere in between. But her hips are what I'm working with, and I feel like that's what I'm checking. I mean, her belly might be right at the edge or even a little bit over, but it shouldn't be like pendulous, like you're worried about her tipping over. Yeah, because that hip is where we're talking about letting that leg drop down over, so if there's a lot of distance there, it's going to get caught from being able to hang. We don't have any 3rd trimester people in here. A little trickier to gauge. Okay. Okay, we're doing okay? Okay. So we're going to switch over into talking about persistent OP presentation. So first note, it's like I had a thought there and it got missed. I don't know what that letter means. So first thing to keep in mind is that most babies will turn on their own. So 15 to 20% of women will be OP at labor onset, but that's going to drop to 5% by the time you get to a birth. And that's just naturally. So that's without us really needing to do anything. That's what's going to happen. That's not to say we haven't had a longer, harder labor to get to that point. but most babies will turn on their own. And usually they'll turn closer to the birth, like right around second stage starting. So it might be a little bit of time. Of OP, most are right OP, 30% are LOP, and then 10% are just direct OP. Risk factors, nulliparity, higher BMIs, older ages, macrosomia, augmenting labor, anterior placentation sometimes. None of these are predictive, but just can sometimes be the case. Epidurals have been shown to have higher rates of OP, even if babies turning from OA to OP. It's not a huge percentage, but it is statistically significant. Sedentary lifestyle in general, which is pretty much America. So I feel like in some ways the intervention has already happened based on heels and desk jobs and everything else, like our society's more likely to present OPs. What would I have meant by, oh, like SROM. It's like range of motion. Rupture of membranes, this is OB. And then, oh, I guess I already had obesity up there. Okay, and then what happens if we have a persistent OP presentation? So thinking about maternal morbidity, prolonged labor, need for augmentation, prolonged second stage, anterior placentation. Oh, that's not really morbidity. Sorry. Operative delivery, severe perineal lacerations potentially, and a higher EBL. And then for babies, they're more likely to have abnormal fetal heart rate patterns, more likely to have low APGARs, meconium, birth trauma, and NICU admissions. So if there's something we can do to fix it, let's fix it. So for diagnosing it, Leopold's maneuver with a vaginal exam is one way to do it. Notoriously inaccurate until the cervix is complete, which I think I talked a little bit about when we did our pelvic exams, but providers are about 80% accurate, 80 to 90% accurate in finding OA presentations, and about 50 to 60% accurate with identifying OP presentations. So we're wrong sometimes, but the more open our cervix gets, the more likely we can correctly identify it. And I've got a couple pictures coming up here that also show you how a gravid abdomen can look different if somebody's OP. So you can kind of combine that with your Leopold's maneuvers. On ultrasound, they're wrong 7% of the time, so it's going to be more accurate. And basically, these are the three things you're looking for. So we don't have to train you in ultrasound, but you can see here the main identifier you're looking for is where you're seeing the baby's eyes. And lining that up with where you're seeing baby spine. Let's see. Okay, so additional findings, you might see back pain, exhaustion, early SROMs more likely with OP, premature urge to push, irregular contraction patterns, cervical edema, persistent anterior lips, because we don't have that head resting like consistently on that cervix. Like sometimes you go in to check the cervix and it's like there's space in the back, like the head is well applied maybe in the front but not in the back as well, and there's kind of a gap back there. That's my kind of clue in the first part of labor where I feel like it's hopeless for me to really try to get good sutures, like with 5 centimeters or something. I don't really think I could probably find everything I need to say we're OP, but I might have a little bit of a suspicion if I notice that space in the back. And then, oh yeah, and then if you've got a really wiggly baby all across the top, that would be another indication. Real quick, let's all make a halo. And then if we tuck our chin in so we're nice and well flexed and we put this down, that's a nice spot, like that vertex spot that we want baby to come down into, versus if we pick our head up and we just pop it straight down. It's not as easy to get it really well applied, so some of that plays into why, because those OP babies aren't going to be as well flexed, that can play into why that labor can be a little bit wonkier too. Okay. And then maternal abdomen. So you can see the baby's OP or OA, but now look at her stomach. You can see that kind of whoosh and that scaphoid curvature. So even just from looking at her, you might have a hunch. I don't think we've got a back across the top. That nice smooth round belly, showing we're probably OA. So we're going to talk about the possibility of turning this baby. And it's worth mentioning sometimes our head does not line up with our back. And babies can do this not as well as owls, but better than we can. So it's important that we know not just where our head is, but where our back is too, so that we're not feeling this and thinking we need to put our face over there, as opposed to we need to put our face this way, right? Okay, thank you, owls. Okay, so what can we do about OP? It's going to depend on who you're asking. A lot of the more formal medical literature is going to say, honestly, if they're not even in labor yet, let's not freak them out, and nothing we do is going to make a difference, and most of those babies are going to turn on their own. So a lot of recommendations around expectant management. There's a good number of studies, both for before labor starts as well as in labor, that being on hands and knees doesn't make a difference. Like, there's been studies that have randomized women to be on hands and knees and to not be on hands and knees, or like be on their back, and it hasn't made a difference for whether or not those babies turn. I try not to freak moms out, basically. But we don't have a lot of studies on spinning baby stuff, which lines up really well with physiology in terms of like actually making more room in the pelvis, and I think we need those studies. So while it's not like super evidence-backed, I think it makes a lot of sense. And not having the evidence, especially if it's safe, not having the evidence doesn't mean that it wouldn't work. It just means we don't have the evidence yet. So that's what I think for a lot of those positions. But ones to consider, especially, I'm not supposed to be saying spinning babies, especially from a position standpoint, would be if you're finding it in pregnancy, recommending sideline release, inversions, and then that rebozo to just kind of loosen things up, shaking things up, see if that baby will just naturally turn. But I do think in the context of if you're feeling anxious as a provider, every once in a while I work with providers that get really freaked out about OP babies in prenatal visits. Like, not have to worry that much. And I think this stat is really helpful for that. So OP presentation before labor does not predict increased risk for cesarean or OP at time of birth. So giving maybe a little bit of permission to be all over the place before we get started. So early labor, same kind of recommendation as above with sideline release, inversions, and rebozo. Better to have mom lie on the side with the OP. So if you're ROP, lie on your right side. If you're LOP, lie on your left side. And that will encourage that baby to be more likely to turn, but also if you're laying on the other side, it'll be more likely to keep that baby there. And then you also want to lunge in the direction of the OP. So if you're right OP, you're lunging to your right side. And then just in general, consider station and where that baby's sitting and how we can make more room there so that that baby can turn. So inlet, mid-pelvis, outlet, that we're making more room. And then active labor, same thing as above, and then you could consider digital rotation if labor progress stalls. So I'm going to talk about both digital rotation as well as manual rotation. Digital meaning you're trying to turn that baby with just 2 fingers versus manual meaning you have your whole hand in her vagina. So I'll talk about digital rotation in a minute, and then manual rotation, you're waiting till she's complete as being an option. So if there's good progress, expectant management. So if you do have an OP baby where labor's just progressing great and it's a multip, and baby's now coming down and we're still OP, but like there's no flags that anything's really abnormal in terms of your labor slowing down, you don't have to do anything. But consider, I know like primips though, primips with OP presentations, it's a 50%, like if that baby doesn't turn, it's a 50% C-section rate, versus it drops to I think 20% if it's a multip. So a primip I'd be much more likely to prophylactically manually rotate, which basically the idea there is for manual rotation, they might turn spontaneously, so on the one hand you don't just want to do it. On the other hand, the farther that baby comes down into that pelvis, if you like get stuck at say +2, where that baby's just not budging and we've been pushing and pushing and we're still at +2, it's going to be harder to rotate that baby once we're stuck. Whereas if you'd done it when they were +1 or 0 and complete, it would have been an easier rotation. So the idea with prophylactic manual rotation is that they've been pushing for a little bit and we're still not turning on our own. So for multips, that could be like 30 minutes, and primips, that could be an hour. And then at that point, if that baby hasn't turned, you could consider turning. We're almost done, so I'm going to keep pushing. Are we doing okay? We're right around noon? Okay. So indications. So Society of OBGYNs in Canada, they say if OA isn't happening spontaneously, that's when we should rotate. All these groups also up to date. Lorraine is another voice that's speaking into manual rotation a lot. So if you have a need for expedited delivery, so maybe heart tones have been bad, we've been pushing with OP for a little while, we're not turning, this baby really should come out, consider manually rotating so we can be born sooner. And then lastly, what I already talked about, like if you've already had a mini trial of labor, you could do a prophylactic rotation. So 30 minutes for a multip, 1 hour for a prime. So risks to rotational procedures, they don't differentiate digital versus manual, and digital is a lot less intense, so probably these are more so with manual. So maternal, potentially cervical lacerations, yeah.
So you're trying to rotate that baby for 30 minutes?
No, you let them push for 30 minutes for a multip, and then if it hasn't turned on its own, then see if you can rotate it. Yep. Sarah, would you mind getting me a baby? Thank you. Yeah, and then an hour for a primip. So cervical lacerations, that's part of the reason why we wait for them to be complete to try a manual. So trying that earlier, you're increasing your risk for cervical lacerations, so it's something we're careful with. And then for fetal, potentially fetal heart rate changes, it's about 1%, so it's not common, but there's a possibility there. Hypothetically, there's a risk if you rotate them the wrong way. So I think multiple studies have said, if you don't have ultrasound available, but you're feeling pretty darn confident about your vaginal exam and lining that up with Leopold, you feel good about where your back's at and where your head's at, not having ultrasound as an option isn't a reason to not try a manual rotation. But if you've got ultrasound at your facility, then I would diagnose it officially with ultrasound so you know exactly where your baby's at, where the back's at, which way we need to go for sure. And then that would mitigate this neck injury possibility. And then hypothetical cord prolapse. If we're rotating, we're not destationing. We're not putting baby's head way up. If we do that, that's where we risk that prolapsed cord coming down, right? And then bleeding potentially for baby. And that's true for mom too, like if she has really low platelets or if baby has a known disorder around that, that would be something to consider too. But also, are you guys familiar with also? American Family Physicians puts out like a one-day intensive that's all things you would need to know about pregnancy and birth complications and what you do for them. I actually think it's great for board review. Like as part of your process to prep, it's like everything that's like memorizable, like crammed into one long day. Anyway, American Family Physicians, AFP. It's a great course. I highly recommend it. And it's at the annual meeting at ACNM every year too. Like if you go a day early, usually that's one of the day-long workshop options. But their recommendation is that manual rotation becomes an attractive alternative during a long second stage of labor because it can be attended during a vaginal exam. And if successful, delivery can be expedited. And if unsuccessful, no harm has been done. So yes, there are risks, but they're not huge, especially if you feel like pretty darn confident with knowing where that baby's at and that you're turning the right direction. That's probably the biggest way you could mess this up. Okay. Contraindications, heavy vaginal bleeding, known compound presentation. Let's not try to turn a bunch of things at once. Cord prolapse, maternal ITP, so again worried about her platelets, or significant android pelvic features, where like if you have a really narrow outlet, are you turning a baby only to then really not be able to get out, would be something to consider. Having this being a VBAC is not a contraindication. One quick study that looked at this was 61 fetuses where they were diagnosed OP in the second stage. So beginning of second stage, we've got 61 babies that are all OP. We did expectant, and then we did a trial of rotating them and delivering in OA. 15% of those where we didn't do anything, they did rotate and they came out OA, versus for the rotational group, 93% came out OA. So some of those were probably unsuccessful rotations. And then for spontaneous vaginal delivery, only 27% of those where they didn't have a rotation came out vaginally, whereas 77% came out spontaneously with the rotational group. And then for vacuum, so some of those OP babies needed a vacuum, and then some of those that were turned also needed a vacuum. And then we look at the cesarean rate. If we didn't do anything, it was 23%. But if we rotated or tried to rotate, none of those babies ended up needing a cesarean. There's another group. I went to a workshop on this at the annual meeting this last year, and she's in San Francisco, and they've been collecting data, and they've got like way more than 61. I want to say 1,500, where they've done manual rotations and kept all the data, and they haven't published it yet, so I can't put that in there too, but there's more coming down the pipeline for why we should be doing this. And definitely the strong recommendation is that midwives and OB providers alike, everybody should be trained how to do this and be doing it. So I would guess that a good handful of your preceptors haven't done this before and wouldn't feel comfortable doing this. Some of them might call in OBs, some of them that just might not be on the table. They might talk about forceps or vacuum in that case. But I want you to have the skill and continue to hone your exam skills with being able to tell where that baby's at, because after you graduate, if it's not a hard procedure, if you feel good that you can do it, do it. You don't need to have watch somebody do it 5 times first. So I'm hoping that you feel like you can have the confidence to try it. Okay, so preparation, empty things if needed. Confirm where baby's at, ideally by ultrasound, but not required. Explain it to the patient, and know which way you're rotating. And you're always rotating the posterior fontanelle towards the fetal back. So you're making that back wander, the head wander towards that back. So if that helps, with moms in all kinds of positions and stuff, that helps you kind of ground where you're going. Posterior fontanelle towards the fetal back. And then be prepared for delivery with sudden descent. So especially if this is a multip where we're slowing up at the end, to get that baby in an OA position, you should have everything ready for a birth because it can go really fast after that. Okay, procedure for digital rotation. So digital rotation you can try as early as 7 centimeters. That's where you just have 2 fingers. And basically what you're doing, we've got our OP baby. What you're doing is you're going in with 2 fingers. Middle finger, you're going to be on the sagittal suture. And your other finger, I'm going to say we're this way, so we're LOP. Your index finger is going to be just anywhere on this parietal bone. We're never pushing into fontanelles. And then you're keeping your middle finger stable, and you're taking this finger and you're rotating it. So that's what you're doing. Less likely to be successful than a manual rotation, but you could try. So as early as 7 centimeters, you could try. So if you've been super, super, super sluggish, ideally you're waiting until we're complete, but if we're just not turning and this labor's a mess, see if you can turn it. So 7 centimeters is kind of enough to get your fingers in there. This one stays steady. I don't understand
how that means you're turning it toward its back. It's already with its back.
So let's say we're feeling like we've got a straight OP. I don't know, kind of like this. Well, if you see this, you know that we need to turn this way as opposed to turn this way.
Right.
I don't know. Is that making sense?
I mean, I get it.
Conceptually, it feels a little funny. Sometimes how their heads are coming down, our back might be not quite how we'd think to line it up there. So I think the tricky part of this is 30% are LOP, 70% are ROP. How many people in here are left-handed? None of us. If you have an LOP baby, you use your right hand because you want to pronate your hand. You're not going backwards. You pronate. If you have an ROP baby, which most are, you need to use your left hand. So like this, and then your turn. Okay? And then manual rotation I'll talk about now. But with both of them, you'll do the same thing to the back. So I'm going to talk about it in the context of manual rotation. So is this some kind of Star Trek maneuver? Okay. It's kind of like that picture, but you can bring both your fingers, not just those two fingers, and you'll get a better grip. So you're reaching in. You've got that sagittal suture, wandering back, wandering back. You've got this lambdoidal suture here. You're reaching in, and your fingers will end up separating a little bit, and that's okay. And it's like you're kind of getting a grip on that lambdoidal suture. You're not pushing into that posterior fontanelle. So you've wandered in. This is your whole hand. You've wandered in, and you're gripping well here. And then this finger, we just don't want it to push up in that anterior fontanelle. So here, wherever it naturally gets a good grip. And now you've got a grip, and you're rotating that baby. A lot more uncomfortable for mom. I think the risk for cervical laceration is going to be higher, but if you're waiting until she's complete and been pushing a little while, then that risk isn't there. So a lot more uncomfortable for mom. That's basically the risk there, but a lot more likely to work. And then while you're rotating, this isn't suprapubic pressure, but with your other hand, or you could have a nurse help you, as you see, because you've got probably all these little hands that have been taking her stomach, right? As you turn, that back's going to be turning on the inside too, and you just take your hand and it's kind of like you sweep and guide those shoulders across.
Or after?
On the outside. Yep. So you're not like pushing in, you're just helping kind of sweep and guide those shoulders across. And you can go to straight away, or you could even go a little further. And then I would keep your hand there for a contraction or two and just let it settle. Other thing, actually, that I should have mentioned too. So get your position set when she's not having a contraction. You're in here, you're ready to go, and then while you're waiting for the contraction, so we're in between contractions, see if you can increase baby's flexion. Okay? And then it's during the contraction that you're turning. Kind of like if you're laying in a hammock, it's loose and you need to roll over and it's kind of hard to get a grip to roll over. You do it during the contraction because the tightness makes it easier to rotate. So in between, we cause better flexion, and then during, we rotate. And it's not going to happen in 10 seconds, but it might take you a minute. So just plan for it to be slow, and you're just really slowly turning that baby. And over the course of a minute, get that baby turned. And if baby's stressed out, I'd be listening at the same time. If baby's stressed out, you can stop. That's 1% of the time. Okay? Great.
Does the station matter?
So it's more likely to be successful, which first attempt, it's about a 70% chance of success. So that's pretty good. If you wait a long time till you're like stuck and wedged at +2 station, it's going to be harder to turn. So you have your whole hand. So like for me, I can only reach so far with 2 fingers. So being 0 versus +1, either way, I'll be able to reach, right? Because it's my whole hand. So in that sense, I don't think it matters. I think the earlier you do it, the more likely it'll probably be successful. But then in the same flavor, it might have turned on its own and then you wouldn't have had to have done it. So pros and cons. Especially because kind of right around complete is when most OP babies will turn on their own. I once had a baby who was crowning OP, and then like this much of the head you see, and it turned. Like right there, we're watching the whole baby turn, and then we came out away. Okay.
Yeah, that's one of the coolest things is watching them move their heads.
Yeah, babies are not passive passengers. So I hope you have the guts to do it. I just went to the workshop on how to do this like in May, and I haven't had an OP yet, but the girl I sat next to, somebody I graduated with, she's done 3 already. She's like, oh my gosh, it's so easy and it works, and then we just have a baby. So definitely there's a push that this is something we should be doing. Okay, and then keeping baby there, you could move her into like a Sims or a modified Sims where she's kind of laying like this on the bed on her stomach, kind of half side. Can just encourage baby to stay there. Holding the head in position through the next contraction or 2 or 3. If you felt like that baby was kind of wanting to rotate back, you could just stay in place for a minute. If you have a mom who was just really pendulous for most of labor, I'd say slap a belly band on. Like, we've got baby in a good position, let's stay there. Yep. And then I think that's all I got. Questions? That's one of our stations, so you can kind of play around with getting your fingers in, what that would feel like this afternoon.
How expensive are those spinning babies workshops to go to?
I tried reaching out to Gail 3 times to see if she would come talk. And honestly, the whole time I felt like we would be able to afford it when we're down at 2. I want to say they're like $350 for the day.
Okay.
I'd strongly recommend it. She has like a 1-day kind of a beginner gig where you'd probably be sitting with doulas or interested people that are sometimes at birth as well as midwives. That one's required before you could do her extended one, and then that's like a 3-day gig, and that's for professionals. Mostly midwives, maybe some others too.
Sure. Lunch is served, basically. We have Caesar salad back there. There's 2 gluten-free and 1 dairy-free for each.
Awesome, thank you.
You're welcome.
So 45 minutes where nothing is required of you.
There's one of these at my spot.
Oh,
and
great.
also where I was sitting.
Okay,
They were different.
extra.
Um,
Should pause Jane's recording.